clinician tell me that she did not want to do CBT because she found it to be boring to do with the clients, and I'm just wondering if you've run into that sort of resistance from a provider before.
I've never heard that. That's really interesting. I mean, I think it's very challenging. It's everyone's different, but I would have to say, from my perspective, I was trained in just more psychodynamic therapy, where you kind of sit around and say, well, how does that make you feel now and again? That can be pretty darn boring. But this one, you've got to be on your toes. You know, you can't. It makes you work harder. It's a lot harder work to do CBT. You've got to be, thinking all the time and getting them through the material, and it's anything but boring. I think it's really pretty demanding. I think, if anything, people don't like to do it for the other reason, that it is a lot. I mean, it's much easier to just sit on your rear end and kind of reflect every once in a while what they're saying than it is to actively, try to figure out how they're behaving and what they're doing, and get them to, challenge their thoughts. It's a demanding treatment as a therapist.
The corollary to that is clinicians who think that they're doing CBT because they learned a little bit about it in one of their classes, but they're not really doing it. They may be using little bits and pieces, and I'm just wondering, I don't know what the research shows, or if you found that to be kind of widespread, that people say, oh yeah, I'm eclectic and I do CBT, but are they really getting good results?
That we now have a number of nice studies of what's called usual care psychotherapy, and that's exactly, people use techniques from all different kinds of therapies, and the outcome isn't ever as good as if you stick with one and go through it, unfortunately. And that model is generally, well, I use it when it comes up, or I use it here or there, and people like to do that. The data would suggest it's not as effective, unfortunately, that you kind of need to pick your model and go through it and really do it. And probably, I think CBT is a little bit hard to learn. When we do trainings, we do videotape, like you guys had. You do a videotape and you get feedback on it. My favorite way is to do co-therapy with people, to teach them. If I can't do that, at least I want, because it isn't so easy to learn to do the whole treatment. You get it after a few weeks, but it's challenging at first. It's a different way to think about therapy. And to try to do it, you absolutely don't want to lose your clinical skills, to do it in a good, people-oriented way and make people feel heard. And I think it's demanding, and it takes a little support at first to learn to do it, but then it becomes second nature after a while, I think.
I seem to have a lot of questions. I have two all at once and kind of unrelated, but one is a gender question. I'm a church-based nurse, and I sit in a church, and most of the people I see are uninsured, low income, and often sick. They're coming to see me for some reason, right? And I notice that, in my experience, women are much more likely to say, I am depressed, than men. So one of you made some comments about that, how do we, as far as a role in people, and some comment on the gender. The other question is, and this is something that just dawned on me as this session went on, is what about getting pulled in? I just realized now that I'm having this problem, that I sometimes get pulled into their depression stories, because their lives are very depressing. Most of these people, a lot of people are homeless, a lot of people I see are undocumented and constantly fearful. I see people who have every kind of drug problem. I see people who, another group of people I see very commonly are people who are not homeless. They are documented, and they're living in a house, but their income is so low, and the pressure's coming at them from so many angles, that I sometimes go, I think I have a hard life, oh my God. And I listen to their story, and what I see is, instead of I'm trying to be therapeutic to them, and the fact that being pulled into their, oh my God.
Yeah.
So those are my two questions.
Those are both great questions. I'll take a shot. You guys can join in. Or the question about gender, and it's a similar, gender and culture are interesting. People will present differently. Like, men are less likely to come in and say, I'm really feeling sad, I've been crying a lot, than women. You're absolutely right. The interesting thing, across cultures and gender, if you ask, have you been feeling sad? Have you been feeling blue? Have you been feeling down? Use a few of those words. people report the exact same symptoms. So it's really important to try to figure out, to look at the guy, and if he looks a little sad, if you can figure out to ask the question. So we think asking is really important across cultures, because generally people do report the same symptoms if asked, but they're less likely to just spontaneously. So that's, so it's having your antenna up. And oftentimes with people who are medically ill, they're complaining about the medical illness, and you have to be listening with a separate ear. I remember I used to teach primary care doctors to learn more about depression, and I was seeing a patient with a guy, and he was heightenedly aware of depression because I was in the room with him. And the patient came in, and she had urinary incontinence. So she said, she's saying, it's just terrible, I hate it, I feel like I smell bad, I don't ever want to go out of the house, I don't want to have sex with my husband, I don't really feel like doing anything. And I'm thinking, she's depressed, because of urinary incontinence has gotten her depressed. But he's thinking only about, I've got to treat her urinary incontinence and she'll be better. So, it's like listening with a different ear. When you start hearing, no matter what the reason, that the person has those symptoms, and which, and that's also related to your second question, is getting caught up in the depression. And it's really true. I tell you, we all struggle with that. I can tell you that when we were doing the We Care study, I did the first groups before we started the study, the pilot groups, and it had been a very busy time. It had been months since I had had dinner with my husband. We went out to dinner, sat down, I had a glass of wine and started crying, and my husband was, oh, shit, this is really fun. And I was just overwhelmed by, particularly in a low-income population, it's just really, really hard. People have really hard lives, and it feels terrible. And, somebody today was saying what they wanted out of this was a team, and I think that what we found in the We Care study is we had to call each other, and we thought of ourselves as a team treating the patient, not me. This patient getting better isn't my responsibility. We're going to do this as a team, and really supporting each other. We would sometimes just call each other up and say, I just have to tell you this. It was just so hard. I was with this woman today, and her husband, is so abusive, and I just needed to tell somebody. So really trying to share it as a team and taking care of yourselves. When I do depression treatment, I do all the assignments myself. I've done it a million times, and I still do all. I try to look at my cognitions. I assign pleasant activities to myself, and, so I think, taking care of yourself is incredibly important. The other is getting caught up in it. When people are so depressed, they will tell you, their life is so negative, and it's the way they perceive it. It's so negative and awful. There's nothing that could ever help. Why would I come to your group? I mean, my boss is so horrible. My husband is so horrible. My dad, is so horrible. And you can believe it. You can really get caught up in it. So you really have to watch it, because over and over again, I've seen that very low income people in rough circumstances. If you work in primary care clinics, you also see lots of low-income people in rough circumstances who feel pretty good. It's the same way with physical disorders. I've always been interested in the fact when you read the chart before you go into the room, this patient has a terrible ejection fraction, their heart's a mess, and they're sitting up there, they're having a good time telling about all they've been doing with their kids, and the next person, has a hangnail and they're hardly able to get their head off. So perception is huge. So you just have to believe that this person doesn't have to feel this bad. That lots of people have had some real bad blows in life and figured out a way. We treated people with such, we had a woman whose son and his fiance lived with her. She was very attached to both of them. The son took drugs, shot the fiance, and she lost both of them. They both, she got better by the end of treatment. That was a very sad event in her life, but she was no longer. So I think you just have to, believe it, that even though really negative things happen, depression is not a given that they can't get over it and come up with a way. So it's tough. It's tough in this patient population. I've always, in my spare time when I retire, I want to write a book on treating depression in people who have real life problems. It's very easy to just believe nothing can.